integration of nutrition into other community-based activities. Janet, what are you doing in Malawi working with a variety of extension workers?
Thank you very much. In Malawi, like I said at the beginning, we started with formative research. So that formative research also informed us that it's possible for mothers to change their behaviors. And then the challenge was, so what? So why not? So the challenge that was also identified was that they don't have anybody to support them at the community level. Much as we have health surveillance assistants who are based at the community level, but they just have got too much to do, from family planning to water and sanitation to everything that you can think about at the community level. So what we've done in Malawi is to engage other community extension workers from Ministry of Agriculture and Ministry of Gender, Children and Community Development, which is what we're doing right now. And the good thing about it is that, for example, the Ministry of Gender, their mandate is to work in the community. And because of that, by engaging them, then it has been easier for us, because it seems they're just continuing on their own role, and we're also taking advantage of the other activities that they already do in the community. For example, Ministry of Agriculture, they normally conduct agriculture shows. So by working with them, we're taking advantage of that and using it as an opportunity for maternal, infant and young child nutrition promotion.
About strengthening of health systems. How does strengthening health systems contribute towards enhanced community nutrition programs? Mercy?
Strengthening health systems, I believe, is the way to go for strengthening nutrition programs in the community, especially in the area of sustainability. In Ghana, this is going on very well and successfully, because at the community level, we have the Ghana Health Service has very well established structures. We have at the district level, you have district team, which also is broken down into sub-district teams, and these are working in the community. Also at the health service are volunteers that are trained, and they work at the community level. We call them community-based surveillance volunteers. So they are at the community level, but they support the government health system to bring nutrition messages and other programs to the people at the community level. Apart from these volunteers, we also have mother support groups at the community level. And so these groups, with training from the government and partners, are able to disseminate the messages that would otherwise be only available at the health facility. They are able to disseminate it at the community level through group discussion, through home-based one-on-one discussions. And so it's helping to bridge that gap between the health system and then the community level.
Now in Ghana, in your IYCM program, you just recently conducted a baseline study, and you were showing us the connection that you used, the relationships you had with the regional and the district. Maybe you can tell our audience a little more about that.
Yeah, there is this beautiful relationship that makes us really happy to talk about, because it assures us that the program will be sustainable, and this is the situation. The Ghana project is currently focused in one of our regions, the Brong-Ahafo region, which is the second largest region. And the region at the health level is led by the regional health management team. So you go into the region, and that's the first person you'd want to see, the first place you'd want to go to. The regional director, who is assisted by the regional nutrition officer, there's the regional health educator, there's the regional public health. And for our project, the regional nutrition officer is our point person or the focal point. Now he oversees all the district activities. We are working in 9 districts out of 22, and the districts are headed by district directors, who are assisted by district nutrition officers, district public health nurses, district health information officers. During our baseline survey, we were going to go into the districts. Our focal person get information down to the district level, and these senior people, these heads at the district level, are the ones who volunteered to come up and conduct the baseline survey with us. They did not use people lower in the community. They could have used the sub-district heads, but they themselves volunteered to come up for the training. And they were very, very participatory during the program. They came up with very realistic suggestions as to how to make things work, which we adapted. And my M&E specialist is here. He testifies to the fact that they had a very successful 2 weeks collecting data. And so in Ghana, I think that what we have is very good, and if the same thing is applied to other countries, things would work. We have very good data. We are just about entering. The cleaning was excellent, and we are happy to talk about it. Thank you.
We have many program implementers in the audience today. Maybe we could talk to them about, you can give them some tips on things that, and how best to replicate some of the approaches you've shared here. And maybe you can also tell them about some gaps that need to be filled and encourage them to go about filling those gaps. Belaynesh, do you have some tips and some gaps?
Yes. You know, in Ethiopia, there is a good opportunity to work on nutrition now, these days. There is a national nutrition program, which is a 10-year program. Phase 1 is already implemented for the first 5 years. It's up to 2013. So by building capacity of the owners to make that program sustainable, we have to build capacity of the Ministry of Health, who is owning this program. We have seen so many projects coming in. When they're out, done. Nothing will be left. So IYCN do not want that to be repeated. What we are doing is building capacity of the Ministry of Health by providing technical assistance. We are providing guideline revisions. We were part of the accelerated stunting reduction program planning. So if the capacity is there, anytime the project will go out and the government will take over that program to make it sustainable. It's not easy to work with something without challenges. There are so many challenges. But you have to press the right key to blast that bomb.
Okay, we're looking at some tips that you can give our audience on applying these community approaches, as well as gaps where you see their needs that they may be able to come in and address in the countries where you're working.
I could say the main gaps, and it's a real need, is in the training, having more trained human resources. And this is one of the reasons the focus, IYCN focus was on designing trainings. And although we have been working on training since 4 years, we're still in need of more trained human resources. And we do think that appropriate training will make a difference in changing health workers' behavior. And if health workers change their behavior, they will be able to support the community and to make changes in mothers, to make changes in fathers and in grandmothers and in the whole community. So this is the gap.
Do you have gaps? Tips?
I think, just to add on to what my friends have said, really, like the case of Malawi, the biggest gap that we see is also in terms of human resources. Because I think, really from the formative research that we had, I will put this, that we saw that it's possible for mothers to change their feeding behaviors. And with the stunting levels in Malawi as high as 48% for the under 5s, And then with the comments, some of the comments that we got from grandmothers, like one grandmother said, I had 10 children, they were healthy at birth, and by the time they are 6 months old, they are no longer healthy. I didn't know what was happening. Now, when you're advising me to feed children and I've seen my grandchild changing, I think this is the way. We feel that in Malawi, if we can really address that gap of human resource, then maybe we'll really make a big impact. So that's one of the gaps. And for the tips, probably what we've seen working in Malawi is planning right from the start with government, where everything seems to be led by government, so much so that ownership is sustained after maybe IYCN is gone. Thank you.
Our lessons from Kenya is that we can work well with other people. Money for nutrition is not, many times it's not adequate, but we can partner with other people, improving what the structures that are at community level from the government and other community-based organizations. It is possible to work with them, to partner with them to get some results for improved nutrition for young children. So partnerships for me is big, even in moving forward. Some of the challenges that we see, before I leave that, is to see also to work with other groups as men and grandmothers. I think that's the way to go. In Kenya, we are clear that probably that's a big missing link. But we need to scale up that. What you've done is showing that it can work. But in moving forward, we need to scale up to get different partners to adapt and engage not just moms, but those who are behind them, who are very, very powerful influencers of decisions at household level. And who are those? Those are grandmothers and their spouses as well, bringing them to the same level. So scale up is a big issue. Resources are scarce, but we can pull together with others to move forward. The linkages with what we are doing at community level and what is happening at facility level is something we could work to strengthen. There's something going on there, but it's a big gap, it's a challenge to think about how to get the two sectors talking back and forth so that we can leverage better on what's happening and have